Okay, so good evening everyone and welcome. So this is going to be one very important session, high yield, concentrating on all the PYQs of FMG, all the PYTs, and I hope that you find the session useful. We are going to concentrate on all the high yield topics, and these are also some of the topics where I expect questions in your exam. So ab ki baar, 200 par. All right, so let's start our session. Let's see the first question which I have brought out for you. Which of the following causes the largest increase in plasma osmolality? So 3 important points, and that is how much is the normal plasma osmolality? Normal plasma osmolality is 280 to 290 milliosmoles per liter. If you have to choose a single figure, then you should say 290 milliosmoles per liter. Concentrate on the unit. This is milliosmoles per liter. Now, what is contributing the maximum to plasma osmolality? And that is sodium. Sodium and its associated anions, they contribute the maximum, that is 270 milliosmoles out of 290. When I say associated anions, sodium is associated with chloride and with bicarbonate. So all these ions put together, they contribute 270 out of 290. But major contribution is going to be by sodium. So very simple, simple clinical application. Hypernatremia will increase the plasma osmolality. Hyponatremia will decrease the plasma osmolality. Yes, Somi Ali, the answer is marked, is already, I'm given it on all the slides. You can sort of ignore it, but this is only so that there is no confusion. And remember, this is a very rapid revision. Now, when you have to see the plasma osmolality, the formula is 2 into sodium plus potassium plus 0.55 into glucose plus 0.36 into blood urea nitrogen. 2 into sodium. Sodium is in milliosmoles per liter, millimoles per liter, and potassium in millimoles per liter. Glucose is in milligrams per deciliter and blood urea nitrogen is in milligrams per deciliter. But finally, the plasma osmolality unit is going to be milliosmoles per liter. So 2 into sodium plus potassium plus 0.055 into glucose, which is in milligrams per deciliter, plus 0.36 into blood urea nitrogen, which is also in milligrams per deciliter. Which is the maximum contributor to plasma osmolality? Sodium. Right, let's go on to the next one. And this says the blood testis barrier is going to be formed by which of the following? Now, blood testis barrier is formed by tight junctions. Tight junctions, these are between the adjacent Sertoli cells. These are your blood testis barrier. This is the tight junctions between the adjacent Sertoli cells. So this is one of the most important functions of Sertoli cells, to form the blood testis barrier. Tight junctions, which are the other places where I will find tight junctions. Tight junctions, these are formed of proteins which are called occludins, claudins, and jams. And what is jams? Junctional adhesion molecules. Junctional adhesion molecules. These are jams. So these are proteins which are responsible for tight junctions. Where do I find tight junctions? Tight junctions are also found between the endothelial cells. Between the endothelial cells of the cerebral capillaries. Cerebral capillaries, and this is what is responsible for the blood-brain barrier. Another question which has been asked. Blood-brain barrier is formed by tight junctions between the endothelial cells of the cerebral capillaries. You must understand, tight junctions do not allow free movement of substances between the two compartments. So tight junctions between the endothelial cells of cerebral capillaries responsible for blood-brain barrier. Tight junctions are also seen between the intestinal epithelial cells, between the PCT cells, between the collecting duct cells towards the luminal side. Towards the luminal side. So these are your tight junctions. So another high yield topic, tight junctions. Let's look at the next one. When ORS is given to a patient, glucose is absorbed by which of the following transport processes? Now, you have to understand that when we talk in terms of orally, glucose requires sodium for absorption. That is why when you see the composition of ORS, electrolytes and glucose. Glucose is definitely a very important component of the ORS, and that is because there is a co-transport. There is a sodium-glucose co-transport, which is an example of secondary active co-transport. So this is your secondary active co-transport. Very important again. Where do you find the secondary active co-transport? This is found in the intestinal epithelial cells. It's also found in the PCT cells. Sodium glucose co-transport, which is also known as SGLT, sodium glucose linked transport. This is an example of secondary active co-transport. So let's see this here. Absorption of glucose is by secondary active co-transport, which is SGLT1. Glucose on the basal side will leave with the help of GLUT2, which is an example of facilitated diffusion. Extremely, extremely important topic. This has been asked so many times in different exams. The questions may be different, so this is a very important topic that you have to focus on, and that is the absorption of glucose in the intestine. This is with the help of secondary active co-transport, SGLT1, and GLUT2, which is an example of facilitated diffusion on the basal side. In the PCT, the absorption of glucose is by SGLT2 and GLUT2. So slight difference here, the subtype of the protein which is present in the PCT is SGLT2 and GLUT2. Especially in the early PCT, SGLT2 and GLUT2, this is responsible for 90% of the glucose absorption. Late PCT has the SGLT1 and GLUT1, which is responsible for about 10% of the glucose reabsorption. Let's look at our next important topic, and this is insulin-dependent GLUT4. This is an example of which type of transport process? Glucose transporters. This is an example of facilitated diffusion. Please remember, whenever we talk in terms of a primary active transport, this will have an ATPase enzyme. The secondary active transport is linked with the transport of sodium. So it is going to be a sodium linked transport. It can be a co-transport and it can be a counter transport. What is simple diffusion? Simple diffusion, which are the substances which move by simple diffusion? All respiratory gases, as well as lipid-soluble substances. They move by simple diffusion. All lipid-soluble substances can easily cross the cell membrane. They move by simple diffusion. So this is an example of facilitated diffusion. Now, this is an interesting diagram which has this image has been asked as a question. So again, an important high yield topic. What happens in facilitated diffusion? The substance which has to be transported will first bind with the transport protein. Once it binds with the transport protein, then there is a change in the configuration of the transport protein. It flips and the substance is transported into the cell. So substance comes from from one compartment to the other with the help of this carrier protein. The substance will bind with this carrier protein, then the protein will flip and it is going to be transported into the other compartment. In this case, the substance is moving from ECF to ICF. So important point here, the facilitated diffusion is a carrier mediated transport. The substance to be transported will bind with this carrier protein. An important point again, whenever a carrier protein is involved, there will be a TM which is present. What is TM? TM is the transport maxima. There is going to be a maximum rate of transport, right? There is a maximum rate of transport, and maximum rate of transport, when I talk in terms of maximum rate of transport, this basically means why is there a maximum rate of transport? Because the carrier protein tends to get saturated. This is because of saturation of the carrier protein. So that means if I study a graph, again, a graph which this graph has been asked, if I have concentration gradient of the substance on the x-axis, rate of transport is on the y-axis, more the gradient, more the rate of transport, this is seen in simple diffusion. Transport is directly proportional to the concentration gradient in simple diffusion. But what happens in facilitated diffusion? More the gradient, more the rate of transport till it reaches what is known as a transport maxima, a maximum rate of transport. What is responsible for this maximum rate of transport, or what is the reason for this maximum rate of transport? Saturation. Saturation of the carrier protein. So all carrier mediated transports will show a transport maxima because the carrier protein tends to get saturated. So facilitated diffusion, like for instance glucose transporters, will show a maximum rate of transport because the carrier protein tends to get saturated. All right. Beam Singh, high velocity, you're finding this a little fast. Should I slow the rate of discussion of these different questions? I wanted to cover as many questions as possible because, like I said, this is a high yield session which is meant for revision of all your important topics. All right. So next question is the positive feedback of which of the following hormones on LH is responsible for the LH surge. And you know that LH surge is responsible for ovulation. Without LH surge, ovulation does not happen. So which is the hormone which is responsible? And that is estrogen. Estrogen has a positive feedback effect which is responsible for LH surge. See what happens to the LH levels? LH level throughout the menstrual cycle is very low LH. This is because of a negative feedback of estrogen on LH. Very low LH levels because of a negative feedback. Estrogen, which is being secreted by the Graafian follicle, has a negative feedback effect on LH, so very low LH levels. But just before ovulation, this negative feedback of estrogen on LH switches. What do I mean by switch? It now changes from negative feedback to positive feedback. What is causing the switch? We do not know. But now, because of a positive feedback on LH, what is positive feedback? Estrogen increases LH, LH increases estrogen, which in turn increases LH, which increases estrogen, which in turn increases. So there's a positive feedback which causes a very sharp increase in LH level. This is called LH surge. And without the LH surge, like I said, ovulation will not happen. This LH surge is due to a positive feedback of estrogen on LH. Then again, switch happens from positive to negative. Estrogen again has a negative feedback effect on the secretion of LH, and the LH levels come back to very low level. So this is your LH surge. LH surge is due to a positive feedback of estrogen on LH. This is what is responsible for LH surge. Absolutely right, future doctor. Mnemonic for positive feedback is CLAPS. I can revise that with you quickly. C stands for clotting, calcium release from the sarcoplasmic reticulum during muscle contraction, A, action potential, upstroke phase of action potential, P, also with A, activation of the inactive pancreatic enzymes to their active form. So we've done L was LH surge, and also milk let down. Once again, let me just tell you, the positive feedback, CLAPS, C, clotting, calcium release from sarcoplasmic reticulum during muscle contraction, L, LH surge and milk let down, A is action potential, upstroke phase and activation of inactive pancreatic enzymes to their active form, P, parturition, S, shock. Shock, uncompensated shock is an example of positive feedback. Absolutely right. Okay, so future doctor has got it right. Medical student, good evening. And yes, BMC has answered for the previous question. So this is as far as your positive feedback is concerned. This particular diagram is something which you are very, very familiar with. I have put this image just to show you what happens to the LH levels. As you can see, LH level very low throughout the menstrual cycle, then because of negative feedback of estrogen on LH, and then suddenly it increases because of positive feedback, and this LH surge is responsible for ovulation, and then again the LH levels will fall. So this is an important diagram, important graph which is asked again and again. Yes, Rafiq Khan, good evening. Good evening. Yes. Let's see the next question. The next one is, a child was defecating in the open in a village when he was attacked by a pack of dogs. One of the attacking dogs was found dead the next day. Considering the high risk of rabies in the child, he was admitted to a district hospital and was given anti-rabies and Rabipur vaccine. Which of the following is responsible for transport of rabies virus to the brain? So when this transport of rabies virus to the brain, this is what is known as a retrograde axoplasmic transport. Right? So firstly, what do I mean by axoplasmic transport? Axoplasmic transport means transport of substances through the axoplasm. Right? That is called axoplasmic transport. And this axoplasmic transport is divided into two types. There is a fast and slow. Fast is further subdivided into anterograde and fast retrograde. Slow is always anterograde. Right? Always anterograde. So now let us see what is anterograde and retrograde. Anterograde means away from the cell body, retrograde towards the cell body. Now, what are the molecular motors which are required for anterograde transport? Anterograde transport uses two molecular motors, kinesin and myosin 5. Retrograde transport uses dynein. Absolutely right. Bhim Singh, Jaideep, future doctor, absolutely right. Dynein is the molecular motor required for retrograde transport. Both anterograde and retrograde need calcium. They need ATP. They need microtubules. Microtubules are the tracks. These are the tracks present within the axoplasm. The motors will move on these tracts. The motors are different for anterograde and retrograde. Anterograde, kinesin, and myosin 5. Retrograde is dynein. Absolutely correct. So this is again another high yield topic that I have discussed with you. Keep in mind the molecular motors which are required for anterograde and retrograde transport. Excellent. Now let's go on to the next. Which of the following electrolyte imbalances results in increased nerve excitability? Increased nerve excitability. Now this is extremely important because both changes in potassium and calcium can affect nerve excitability. Hyponatremia and hypochloremia do not have an effect. So let's rule that out. But both hypokalemia and hypocalcemia can affect nerve excitability. So what is the effect? Now, if there is a hypokalemia, yes, future doctor, don't concentrate on the answers. Answers may even be wrong. So don't go by that. See what is your, are you able to answer yourself? So you've got to test yourself. Don't bother looking at the answers, may be wrong. Don't worry about it, right? To remove answers now would be a little difficult. So like I said, ignore the answers. They may be wrong. They're not supposed, they may not be, they're not absolutely correct. Okay, so let's see. Now let's try and understand this particular concept, this particular high yield topic. Now, hypokalemia. Hypokalemia causes, whenever there is a decrease in the ECF potassium, there is more loss of potassium from inside to outside the cell. There is an increased movement of potassium from inside to outside the cell. There is increased efflux or movement of potassium. Movement of potassium from inside to outside. So if there is more movement of potassium from inside to outside, there is more loss of positive charge. So what will happen to the potential? The resting membrane potential becomes more negative. If it becomes more negative, we say that the cell is hyperpolarized. This leads to a hyperpolarization of the cell. That means normally the resting membrane potential of the cell of a neuron is, most neurons is -70. If I have more loss of potassium from inside to outside, this resting membrane potential will become more negative. When I say more negative, that means it may be -80 or -90 millivolts. So what will happen to the cell? We say that the cell is hyperpolarized, right? So when a cell is hyperpolarized, what is going to be the excitability of the cell? Reduces. There is a decrease in excitability. Have you got my point, right? So hypokalemia, question says increased nerve excitability. Yes, some of us would have gone for hypokalemia, but please remember hypokalemia is going to reduce the nerve excitability, not increase it. On the other hand, hyperkalemia has got a dual effect. If it's a mild to moderate hyperkalemia, it will increase the nerve excitability. If it is a severe hyperkalemia, this in fact reduces excitability, right? Let's see this once again. Do not concentrate so much on the question, concentrate on the topic, right? These are all high yield topics. So, hypokalemia causes hyperpolarization and reduced excitability. This is very commonly seen in patients. Sometimes when a patient is on long-term Lasix, loses a lot of potassium. Of course, with Lasix, you give potassium chloride, pot chlor. But sometimes patient goes into hypokalemia. And what is the complaint of the patient? He says, "Haathon पैरों में जान नहीं है," right? He feels weakness in his limbs. Why is the weakness? Cells are hyperpolarized and reduced excitability. Which are the two excitable cells in the body? Neurons and muscles. Both have got a reduced excitability, and that means that is what is seen with hypokalemia. In hyperkalemia, on the other hand, dual effect. Mild to moderate, increased excitability. Arrhythmias are a very common feature of mild to moderate hyperkalemia. Severe, now what is severe hyperkalemia? Severe hyperkalemia means when the potassium level is more than 8 to 10 milliequivalents per liter. Severe hyperkalemia, there is decreased excitability and decreased contractility. Severe hyperkalemia will lead to death because the heart will now stop in diastole. Remember, that is in a severe hyperkalemia. Okay, got it? Again, hypokalemia, hyperpolarization, reduced excitability. Hyperkalemia has got a dual effect, mild to moderate increased excitability, and severe hyperkalemia decreased neuronal and muscle excitability, leading to death because the heart stops in diastole. Now let's see what is the effect of hypocalcemia. Hypocalcemic tetany. This is what is known as the Trousseau sign, yes, carpopedal spasm. Now what is the reason for, what is tetany? Tetany is now, there is an alteration in the electrical property of neurons and muscles. There is an increased neuronal and muscle excitability, which causes carpopedal spasms, right? So now let's try and understand why. Because remember, here the reason is completely different. Calcium, changes in calcium levels do not affect resting membrane potential. Changes in potassium is affecting resting membrane potential. But here, why is there an excitability? Very interesting reason. Now this is a sodium channel. Sodium channel is lined by negative charge. Sodium will go from ECF to ICF through a sodium channel. This is a voltage gated sodium channel. When do voltage gated sodium channels open? Whenever a cell is excited, stimulated, right? Now, calcium, which is the second most abundant ion in the ECF, it tends to stand around the mouth of this channel. It does not go through the channel, it tends to stand around the mouth of the channel. And I always say, what is the role of calcium? Calcium is like a chowkidar. C for calcium, C for chowkidar. So if there is a chowkidar outside a building, there is a regulated entry, right? There's no free entry, right? You have a chowkidar outside the girls' hostel, there is no free entry, there is a regulated entry, right? So this regulates the entry of sodium through the sodium channel. But if the chowkidar goes on chutti, he's gone on leave, now what happens? This calcium has gone. So now there is a free entry of sodium into the cell. So what happens to the excitability? Increases. We say that calcium has a membrane stabilizing action. Membrane stabilizing action. So hypocalcemia causes loss of this membrane stabilizing action. This results in increase in the neuronal and muscle excitability, resulting in Schwarzschild sign positive, Trousseau sign, etc. Have you got this? Are you absolutely clear? Hypokalemia, hyperpolarization, reduced excitability. Sorry. Okay. Hypokalemia, hyperpolarization, decreased excitability. Hyperkalemia, dual effect. Mild to moderate, increased excitability. Severe hyperkalemia, reduced excitability and contractility. Hypocalcemia increases the neuronal and muscle excitability. So I hope this is absolutely clear. All right, is this clear? These concepts are clear? Beam Singh, Rafiq Khan, future doctor. All right, let's look at the next one. A patient with HbA1c of 11.4%, so uncontrolled diabetes, has come to your clinic with severe pain in his feet at night. Which nerve fibers are going to be involved? Diabetic neuropathy is a very, very common problem. And the moment I say pain, now which are the nerve fibers which are associated, which are responsible for carrying pain? Your answer is going to be type C fibers. Type C fibers carry pain. So these are the ones which are getting affected, and that is why he's complaining of pain at night. Absolutely right. Yes, the type C fiber. All right, let's see the next one. A cross-sectional view of the skeletal muscle fiber through the H zone would reveal what? So you've got the A band. So if there is a cross-section through the A band, what is A band? The dark band. This will have myosin plus actin. Within the A band, there is a slightly lighter area, which is called the H zone. H zone has only myosin. On either side of the A band is the I band. I band has only actin. Right? So answer to this question becomes myosin only. So I told you these answers are not correct. Right? So this was basically to make sure that you do not concentrate only on the answers. So there you have myosin, only myosin, not both. Both will be through the A band. H zone has only myosin. So if I take a cross-sectional view through the H zone, there will be only myosin. A band is myosin plus actin. I band is only actin. Are we clear with that? Right? Okay, so future doctor, just a little clarification before I move on. You said for pain, C fibers, also A delta. Yes, absolutely right. But please remember, the A delta fibers are responsible for what is known as fast pain. What is fast pain? When you touch something hot, the pain that you feel which makes you withdraw your hand, that is fast pain. That is by A delta. So that's only for a very brief period of time. But the pain due to tissue injury, that is by the C fibers. That is called slow pain. So for pain, if you're asked a question, you should say C fibers. If you're asked a question, which are the fibers for fast pain, then A delta, slow pain, C. But only pain is asked, then your answer is C. Is that clear? Okay. So if you look at this one important diagram, one important image, this is what is known as the Z line. Between the two Z lines, you've got the sarcomere. What is the sarcomere? It is the it is the structural and functional unit of the skeletal muscle. So C is the sarcomere. Between the two Z lines is sarcomere. What is A? A is the dark band. And what is dark band? This has got myosin plus the overlapped actin. Within the A band, you have a slightly lighter area which is called the H zone. So D is H zone. And what is H zone? Only myosin. Can you make out? This here in the middle is the M line. On either side of the M line is this D, which is the H zone. Only myosin. On either side of the H zone is the light band. This is the light band or the I band, which has got only actin. Is that clear? Has everybody got this particular diagram? Remember, half of I band lies in one sarcomere, half lies in a neighboring sarcomere. So when I look at a sarcomere, it is half of I band plus A band plus half of I band. Is that clear? This is what is a sarcomere. Has everybody got this concept as well? PK, MKB, why are you crying? क्यों भाई रो क्यों रहे हो? Physiology के साथ रोना? अरे नहीं. Physio is a high yield subject, little bit of effort from your part, and I can assure you, you will be able to do very well. Okay, let's go on to the next one. Gover's sign, right? What is Gover's sign? When you ask this child to get up, he climbs on to himself to get up, isn't it? That is what is known as Gover's sign. So Gover's sign has been demonstrated in a 5-year-old child in your OPD. Workup shows no functional dystrophin protein. So when there is no functional dystrophin protein, dystrophin may be present, it is altered, it is mutated, but it is functionally absent. There is no functional dystrophin protein. Which of the following is the most probable diagnosis? Duchenne's muscular dystrophy. In Becker's muscular dystrophy, functional dystrophin is present but reduced, right? So there is a decrease in the functional dystrophin. Both are genetic conditions. This is Duchenne's is absent functional dystrophin. Becker's is a decreased functional dystrophin. It is present but reduced. Now, what is the characteristic feature in a child with Duchenne's muscular dystrophy? A severe proximal muscle weakness. Now, which are the sarcolemmal proteins? What are the sarcolemmal proteins? Sarcolemmal proteins are also known as the dystroglycan, sarcoglycan complex. Dystroglycan, sarcoglycan complex. Which are the sarcolemmal proteins? Number 1, dystrophin. Number 2, syntropin. Number 3, sarcospan. Number 4, dystroglycan. And number 5, sarcoglycan. These are your sarcolemmal proteins. Remember, laminin, which is shown here, this is a protein in the extracellular matrix. This is not a sarcolemmal protein. So that means, once again, which are the sarcolemmal proteins? Again, a question which has been asked. For all of the following are sarcolemmal proteins except, once again, dystrophin, syntropin, sarcospan, dystroglycan, sarcoglycan. Next important question here is which dystrophin links which two proteins? It is linking actin. It links the actin with the beta beta-dystroglycan. It is a bridge between the actin and beta-dystroglycan. Again, this has been asked as a question, so very, very careful. Dystrophin is a rod-like protein, so it links actin and beta-dystroglycan. What is the role of dystrophin and other sarcolemmal proteins? They are involved in amplification of the force generated by actin and myosin. That is why mutation of these proteins is associated with muscle weakness. Is that clear? Aditya Das, yes, DMD. Gover sign is typically seen in Duchenne's muscular dystrophy. Let's see the next question. A child is brought by his mother with complaints of weakness, difficulty in walking, climbing stairs. He is not able to do day-to-day activities. His calves are bilaterally hypertrophied. Which of the following deficiency is the cause? So again, this is very clinical condition, Duchenne's muscular dystrophy, and my answer will be dystrophin. Dystrophin is the link between, it links or attaches, it is the link between actin and beta-dystroglycan. This is a question which also has been asked. Okay, let's go on to the next topic. A patient having unilateral drooping of eyelid, muscle weakness, headache, symptoms worsen during the evening. Patient feels better while taking neostigmine. What is the probable cause of the patient's condition? So worsens, that means his weakness is less in the mornings, more in late evenings. So this is typically seen in myasthenia gravis. What happens in Lambert-Eaton syndrome? In Lambert-Eaton syndrome, the weakness is more in early mornings. Here, the weakness is more in late evenings. So a brief recap of the neuromuscular junction, another high yield topic. Firstly, whenever the moment action potential reaches the end of the A-alpha motor neuron, it causes opening of which channels? It causes opening of voltage-gated calcium channels. And once the voltage-gated calcium channels open up, there is an influx of calcium and exocytosis of acetylcholine. The neurotransmitter released is acetylcholine. Acetylcholine will diffuse across its synaptic cleft and bind with acetylcholine receptors. Where are the acetylcholine receptors present? On the muscle fiber membrane, on what is known as the motor end plate, muscle fiber membrane. Next important point, what are these acetylcholine receptors? They are ligand-gated channels. They are ligand-gated sodium and potassium channels. Once again, action potential reaches the end of the A-alpha motor neuron, causes opening of voltage-gated calcium channels, influx of calcium, exocytosis of acetylcholine. Acetylcholine will diffuse across the synaptic cleft and bind with acetylcholine receptors. What are these acetylcholine receptors? They are ligand-gated channels. They are ligand-gated sodium and potassium channels, but the movement of sodium predominates. So if you get a question, are they ligand-gated sodium channels or ligand-gated potassium channels, your better answer is sodium channels. But if you have an option which says these are ligand-gated sodium and potassium channels, that is the best answer. But remember, movement of sodium predominates through these channels. Now, what is Lambert-Eaton syndrome? Lambert-Eaton syndrome is the antibodies are against acetylcholine receptors. It is, Lambert-Eaton syndrome is a disease of the presynaptic membrane where antibodies are against voltage-gated calcium channels. Myasthenia gravis is a disease of the postsynaptic membrane where antibodies are against the acetylcholine receptors. In Lambert-Eaton syndrome, the maximum weakness is in the mornings. Repeated stimulation during the day causes more and more calcium to accumulate and increases release of acetylcholine. So weakness improves as the day progresses. This is a characteristic feature. On the other hand, in myasthenia gravis, the maximum weakness is in the late evenings. Why so? This is because repeated stimulation during the day will cause more acetylcholine release, and acetylcholine will get depleted. So this results in a greater weakness in late evenings. So these are two, again, and very, very high yield topic. Absolutely right, future doctor. Myasthenia gravis was the answer. Weakness in myasthenia gravis, maximum weakness is in the late evenings. In Lambert-Eaton syndrome, maximum weakness is in the mornings. Okay. Any questions? Any questions so far? Let's go on to the next one. It says, you are performing a CNS examination on a patient with a stroke. With his eyes closed, you move his big toe up or down while holding his metatarsophalangeal joint. Isn't it? We do this for position sense. You remember your CNS examination? Position sense. You ask him to state the position of the digit. Which of the following fibers is responsible for transmission of the sensation tested here? So, position sense, or also known as proprioception. So, for proprioception, both A alpha as well as A beta, A alpha as well as A beta are involved. For proprioception, both A alpha and A beta are involved. Right? But my slightly better answer here will become A alpha. I was waiting for an answer here. Right? So, proprioception, your better answer is always A alpha. Again, A alpha is the largest diameter nerve fiber, fastest conducting. This also has been asked as a question, which is the fastest conducted sensation. And your answer in that case is, fastest conducted sensation is proprioception, because it is carried by A alpha, mainly A alpha. Is that okay? Has everybody got this? Any questions? All right. Let's look at the next one. Decussation of the ascending spinal pathways occurs mainly within which of the following? Now, ascending spinal pathways, which are the major ascending spinal pathways? You have the posterior columns, and the spinothalamic tracts. They cross over to the opposite side, right? Posterior column is also known as the dorsal column, medial lemniscal pathway. Yes, Bhim Singh, absolutely right. A beta for fine touch, for deep pressure, for vibration, also for proprioception, but the better answer is going to be A alpha. Absolutely right, Bhim Singh. All right, so this is your dorsal column medial lemniscal pathway. Now, both of these are your ascending tracts. A very, very important high yield topic. What are the sensations carried by these different tracts? So, posterior column is meant for fine touch. It is meant for localization. It is meant for proprioception. It is meant for vibration. This is meant for stereognosis. spinothalamic tracts, you have a lateral spinothalamic tract which is meant for pain and temperature, and the anterior spinothalamic tract which is meant for crude touch, itch, tickle, sexual sensations, and barognosis, detection of pressure, right? Barognosis, right? So these are anterolateral is, for anterior and lateral spinothalamic tracts are meant for, lateral is meant for pain and temperature, and crude touch, anterior spinothalamic tract for crude touch, itch, tickle, sexual sensations, and barognosis. All the finer sensations like vibration is, future doctor, just make that correction. Your finest vibration is a finer sensation. This is carried by the posterior column, right? So fine touch, localization, proprioception, vibration, stereognosis, 2-point discrimination is by posterior column. Is it okay? Future doctor, have you understood that? Is it okay? Anterolateral tracts are involved in a lateral spinothalamic tract, pain, temperature, crude touch, itch, tickle, sexual sensations, and barognosis. Is it okay? All right. So next, let's see where do these tracts cross. Remember, crossing in both the posterior column and the spinothalamic tract is done by the second order sensory neuron. Second order sensory neuron. Second order sensory, both. In both the cases, it will be the second order sensory neuron. But the crossing in the case of the dorsal column or the posterior column, yes, or the dorsal column medial lemniscal pathway will be at the level of medulla. But in the case of the spinothalamic tract, it will be the spinal cord. Both the tracts will cross over to the opposite side. In both the cases, it is the second neuron which crosses. But the level of crossing is different. For posterior column, it will be the medulla. For the spinothalamic tracts, that is the anterolateral tracts, it will be the spinal cord itself at the level of entry or 1 to 2 levels above. So let's go back to the question which was asked. Decussation. Decussation means crossing over to the opposite side. Is in which of the following of the ascending spinal pathways? One is medulla, the other is spinal cord. So your answer is spinal cord and medulla. Has everybody got this? Extremely high yield topic. We should expect a question from this. From this one slide, we should expect a question. Future doctor, have you got this clarification? Anterolateral system is meant for the cruder sensations. Posterior column is meant for finer sensations. ये सब localization, 2-point discrimination, vibration, proprioception, ये सब finer sensations है. Have you got my point? Yes? Move on. Okay. Brown C card. Again, extremely high yield topic. Brown C card. It leads to damage to which of the following? Now, in Brown C card is a hemisection of the spinal cord. This is the cross section of the spinal cord. Hemisection. Half of the spinal cord is now cut. So that means all the ascending tracts will be affected and the descending tracts will also be affected. Which are the ascending tracts? Ascending tracts are carrying sensory. Ascending tracts are sensory. Isn't it? We just discussed posterior column, anterolateral pathways. These are sensory. Descending tracts are motor. Right? They are carrying impulses from the brain to the spinal cord and then to the muscle, responsible for movement. Yes? So that means which are the ones which are going to be damaged? The ascending sensory and descending motor pathways. Have you got my point? All these ascending sensory and descending motor pathways will be affected. Have you got my point? Sensory are ascending are sensory, descending will be motor. Right? So all the other combinations do not make sense. So if you see this over here, if you see a cross section, this is of course an anatomy slide. You can see dorsal columns, the ones in yellow. The ones in yellow, these are your sensory. The ones in green are your motor. Right? Yes, never give up. Oh, you did not get your notification? Okay, I'll ask the concerned people to look into it. Okay, future doctor absolutely right. So dorsal column, and you also have the anterior and the lateral spinothalamic tracts. Yes, and you also have a spinocerebellar tract which carries sensations, unconscious proprioception to the cerebellum. Spinocerebellar. Motor is given in green, lateral corticospinal tract and the anterior corticospinal tract. So all the ascending as well as the descending, ascending sensory and descending motor will be affected. Has everybody got this? Can I move on? Never give up. Never give up. What a lovely name. Yes, and that is exactly what is important when it comes to the exam. I want you to have complete faith in all your preparation that you have done. I want you to have complete confidence in yourself. Whatever you have done, whatever you have studied will come in handy for your exam. Don't worry, but important thing is keep calm. Keep your confidence levels high. That, I always say these exams are a battle of nerves. Keep calm, keep cool, be confident, and you will be able to do well in the exam. But you have to, like I said, control your anxiety, control your, that little bit of nervousness that you have. And deep breathing exercises are always helpful. When you do deep breathing exercises, it increases the parasympathetic discharge, right? And if the vagal discharge increases to the heart, what will happen to the heart rate? Reduces, right? So if there is a situation where you're feeling very nervous, take a few deep breaths and you will feel that you are, there is definitely a decrease in heart rate. Okay? All right, great. Okay, so Bhim Singh says, I am confused in what happens. Which are the ones which are lost on the same side and which are lost on the opposite side. So let's see this. Now, look at Bhim Singh. Remember bus stop. Brown C card. Temperature and pain of opposite side is lost. Of course, below the lesion. Right? Below the lesion. So remember bus stop, है ना? Bus stop पे खड़े हैं, तो BS here is Brown C card. Temperature, sorry, I think it's getting hidden. I'll just write it once again. Okay. So first thing is, like I said, bus stop. Brown C card, temperature, pain of opposite side is lost. This is because the anterolateral system crosses at the level of the spinal cord. So opposite side. So bus stop. Okay? Second is touch is least affected. Second important point, touch is least affected. Why is touch is least affected? Because touch has got a dual transmission. Same side, posterior column carries fine touch. Opposite side, anterior spinothalamic tract transmits crude touch. Okay, so touch is least affected. All other sensations lost on same side. So iska matlab, which are the ones which are lost on the same side? Vibration, localizing, all that will be lost on the same side. That means basically all posterior column sensations will be lost on the same side. Is it understood? Bhim Singh. And number 4, motor paralysis, same side. Motor paralysis, same side. Is that clear? Bhim Singh, 4 important points about brown sea card. Bus stop, pain temperature, opposite side is lost. Touch is least affected. All other sensations lost on same side. All posterior column sensations, same side. Motor paralysis, same side. Bolo. Okay? Bhim Singh, got it? Can I move on? Let's have a look at the next question. A 25-year-old patient with a head trauma presented to the emergency room. On neurological examination, he was found to have a normal handwriting and could copy shapes of objects but could not speak. So that means he's able to understand, he is able to write, he's able to read. Yes. Yes, never give up. You have explained it beautifully. Right? Much better than me, right? Okay. All right. So, so here look at this question. This is normal handwriting and could copy shapes of objects. So his reading is intact, but he's not able to speak. Now, which is the motor area for speech? The motor area for speech is the Broca's area. Absolutely right, Aditya Das. Bhim Singh. Yes, I'm so glad that you've got the concept, and Aditya, absolutely right. Motor area is the Broca's area, which is the area which is meant for comprehension of the spoken word and the written word is Wernicke's area. So here he's able to read, yes, so that, and he's able to copy the shapes of objects, so his Wernicke's is intact. Where is the Wernicke's area located? Now, when you look at firstly, where is the Broca's area? Broca's area is in the lower part of the motor cortex, inferior end of the motor cortex in the frontal lobe. This is involved in motor aspect of speech. And if this area is affected, motor aphasia, which is also called non-fluent or expressive aphasia. He's not able to speak. He's not able to express himself. Whereas in the case of, if the lesion is in the Wernicke's area, where is the Wernicke's area? This is in the posterior end of the superior temporal gyrus. This is the area which is involved in comprehension of both the written and the spoken word. So in this case, if only lesion is in the Wernicke's area, he's able to speak, but the speech which comes out is nonsensical. It's fluid, he's able to speak, but it does not make sense. So that is known as a fluent aphasia, right? He's able to comprehend. Wernicke's area is involved in comprehension. So if there is a lesion of Wernicke's, then comprehension is lost. Broca's in that case will be intact. So he's able to speak, but it does not make sense. So it's called fluent aphasia, right? And angular gyrus, which is involved in the processing of visual information and the written word, the lesion here is going to be anomic aphasia, right? Okay. All right. So remember, Broca's for motor aspect of speech. Lesion of Broca's gives rise to a non-fluent expressive or motor aphasia. Wernicke's is involved in comprehension of both the written and the spoken word. Lesion of Wernicke's will give rise to a fluent aphasia. Angular gyrus is involved in processing of the visual information and the written word. So it gives rise to what is known as anomic aphasia. Okay? Okay, let's go on to the next one. In which stage of sleep are K complex and sleep spindles seen? Now please remember, in REM sleep, beta waves. Stage 1, alpha. Stage 2, along with alpha, there are K complexes and sleep spindles. Stage 3 will be delta, right? In stage 4, NREM, delta will become prominent, right? Okay. Aditya says in Wernicke's, if the lesion is in the Wernicke's area, can he write? Again, it does not, he may be able to write, but it's not going to make any sense because he's not comprehending it, comprehending your instructions. He's not able to understand what you want him to do. You may give him a pen, he may write something which is not going to make any sense. Have you understood? Right? Okay. All right. So the question says, K complexes and sleep spindles will be seen in stage 2 NREM. Right? Stage 2 NREM. Okay. So let us see what is a sleep cycle. Sleep cycle is first when you're awake, eyes closed, mind wandering. Then this is the time. Sorry, I've made a mistake here. Just correct this, please. This has to be, stage 1 has to be theta-like activity. Please make this clear. Please, it's not alpha, it is theta-like activity. Sorry, I made that little mistake here. Okay, so let's see this. Now, when he's awake, eyes closed and mind wandering, this is alpha, right? Eyes are closed, mind wandering, that is alpha. When he goes into stage 1 of NREM, there is a decrease in frequency. The wave which has got a lower frequency than alpha is theta. So you get theta-like activity. Then he goes into NREM. This is where you get K complexes and sleep spindles. Please, I'm making a correction. I told you NREM sleep 1 is alpha, which is incorrect. Stage 1 is theta-like activity, right? NREM delta. Delta will be seen, right? Delta will start appearing in NREM. In NREM stage 4, delta becomes prominent. This is your deep sleep, right? Then he goes into REM. In REM, you will record beta. The time spent in REM is 5 to 30 minutes. Then he goes into NREM 2, then 3, 4 REM, 2, 3, 4 REM. It's like that. It's a sleep cycle. This cycle occurs every 90 minutes. Okay? So this is as far as your remember. How do I remember the different frequencies of the EEG waves? Remember D-tab. D-tab. As you go from delta to beta, there is an increase in frequency, but there is a decrease in amplitude. Highest frequency wave is beta. Largest wave is delta. So delta looks like this. Largest wave, large amplitude. Beta is chota sa wave, small amplitude but very high frequency, right? So remember D-tab, delta, theta, alpha, beta, right? So from as you go from delta to beta, there is an increase in frequency and decrease in amplitude. So that is why I said when he's awake, eyes closed, mind wandering, the frequency of the EEG wave reduces. Eyes closed, awake, eyes closed, mind wandering, EEG wave is alpha. A wave with lower frequency than alpha is theta. So that is why stage 1 is theta-like activity. Then stage 2, K complexes and sleep spindle. Stage 3, delta will make an appearance. Stage 4, delta becomes prominent and then he goes into REM. REM is characterized by beta waves. Is that clear? Okay, so let me see. Never give up says, yes ma'am, got it. Never give up says, in NREM stage 3, first time delta will start and maximum seen in NREM 4. Absolutely right. Yes, clear. Never give up says stage 3 delta. Yes? All right. So in fact, stage 3 and 4 are also known as slow wave sleeps. Slow wave sleep, right? Some people say NREM it should be called slow wave, but the better thing is stage 3 and stage 4 are known as slow wave. That means delta. Delta has got high amplitude, less frequency. So slow. Beta is low amplitude, high frequency. As you go from delta to beta, D-tab. Delta, highest amplitude, less frequency. Beta, lowest amplitude, higher frequency. Is that clear? All right, let's go on to the next one. In a patient suffering from Parkinson's disease, what is the most likely reason behind the gradual decline of the therapeutic effect of L-DOPA? This is because in Parkinson's disease, we know that which part of the basal ganglia is going to be affected? Substantia nigra pars compacta. This is something which we see very commonly. You're giving the patient L-DOPA, but he continues to show some deterioration. That is because the dopaminergic neurons in the substantia nigra pars compacta continue to degenerate. Right? It is a degenerative condition, isn't it? Patient progressively worsens. Of course, there are a lot of talk about stem cells and this, that, and the other, and we may find a cure for or we are close to finding a cure for Parkinson's, but at the same time, it is a degenerative condition. Yes? So, again, another high yield topic. Which neurotransmitter from which part of the basal ganglia and what is the disease? So, caudate nucleus and putamen. So, this is a little mistake here. Caudate nucleus and putamen are known as striatum. Caudate nucleus putamen globus pallidus is known as the corpus striatum. So first difference is, if you are asked which is the striatum, that means caudate nucleus, putamen. But if the question says which is the corpus striatum, that is an anatomical classification, then it is caudate nucleus, putamen and globus pallidus. So important. So striatum is a term we use in physiology. Corpus striatum is used in anatomy. Corpus striatum, why is it called corpus striatum? Because it has a striated appearance in the under the microscope, right? So caudate nucleus and putamen is striatum. Now, which is the major neurotransmitter secreted by the striatum is GABA. 95% of the striatal neurons secrete GABA. 5% will secrete acetylcholine and somatostatin. Now, striatal lesion causes chorea, but a more specific answer is caudate nucleus lesion causes chorea. So, if you have an option, chorea is caused by lesion of the caudate nucleus. That is a better answer. But if caudate nucleus is given, if striatum is given, then go ahead and mark striatum. Okay? Globus pallidus external segment secretes GABA, internal segment secretes GABA. A lesion of globus pallidus gives rise to athetosis, slow writhing movements. Substantia nigra pars compacta neurons secrete dopamine, lesion causes Parkinson's. Substantia nigra pars reticularis secretes GABA. Subthalamic nucleus of Lewis secretes glutamate and the lesion is hemibalismus. Right? So once again, question says striatum, caudate nucleus putamen, corpus striatum, caudate nucleus putamen, globus pallidus. Lesion of striatum, chorea. Better answer, caudate nucleus, chorea. Globus pallidus lesion, athetosis. Substantia nigra pars compacta, Parkinson's, and subthalamic nucleus of Lewis, hemibalismus. Is that clear? Okay. Never give up, substantia nigra, dopamine, okay, fantastic. Okay, important high yield topic. Next, an experimental animal monkey develops increased sexual activity, so there is hypersexuality, there is increased appetite, anger, no fear, following bilateral removal of a certain area of the brain. Removal of which of the following structures is responsible for the above mentioned changes in behavior? Now, the answer to this question is amygdala. Amygdala is located at the anterior pole of the temporal lobe. So, if I remove the anterior-most part of the temporal lobe bilaterally, then this animal shows all these features. This also happens in certain patients. So, let's see. Now, when I say this is also known as, there is a bilateral ablation of the amygdala, destruction of the anterior poles of both temporal lobes. This gives rise to what is known as the Kluver-Bucy syndrome. So this monkey has got a snake in his hand. He's not scared, so there is no fear. He's not afraid of anything. Right? He has extreme curiosity about everything. Forgets very rapidly, increased oral tendency. He takes whatever is present around him, he tends to put it in his mouth. There is a hypersexuality. He starts performing the sexual act with other animals, immature animals, even animals of some other species. Right? There are decreased emotional responses. So these are all features of Kluver-Bucy syndrome. Okay? Okay, never give up. How do I hide the answers? Okay. There is no way for me to hide the answers. And like I said, don't concentrate on the answers. Answers may be incorrect. Don't worry about it. Okay? Focus on the topic. Focus on the topic which I'm discussing with you. All right? Okay. Don't bother looking at the answers. Like I said, answers will be incorrect, can be incorrect. I don't have any way of hiding the answers, unfortunately. All right. Okay. Okay, let's see which is the next one. Which of the following statements is true about the GFR? Increased renal plasma flow increases GFR. Increased sympathetic. So if you have more renal plasma flow, if you increase the renal plasma flow, so there is an increased glomerular capillary flow. More the glomerular capillary flow, it will increase what is known as PGC, hydrostatic pressure of the glomerular capillaries. Hydrostatic pressure of the glomerular capillaries is a force which favors filtration. This will increase the GFR, right? This in turn increases the GFR. So more the flow into a capillary, more is the hydrostatic pressure. What is hydrostatic pressure? Hydrostatic pressure is pressure due to a column of liquid, column of fluid, right? So more hydrostatic pressure. Hydrostatic pressure, remember, is the push force. Hydrostatic pressure is the push force. H in hydrostatic, H in push. So more the hydrostatic pressure, more will be the GFR. So this is a correct option. But let's see the others as well. Increased sympathetic discharge leads to increase in GFR? No. When I do a sympathetic discharge, it causes afferent arteriolar constriction. This causes a decrease in the glomerular capillary flow. This causes a decrease in PGC, which in turn decreases GFR. Okay? So if there is an afferent arteriolar constriction, less flow, less PGC, less GFR. So this is, both are incorrect. Decreased renal plasma flow increases GFR. If I decrease the renal plasma flow, there will be a decrease in GFR, not increase. So my answer to this question becomes A. More the flow, more the pressure due to a column of liquid, column of fluid, more hydrostatic pressure, more PGC, which is a push force, and it pushes and it causes more glomerular filtration, increasing GFR. Okay. Never give up says B. Leads to increased sympathetic function will lead to. All right. Okay. So you have to remember, when there is a constriction of, in this case, for example, sympathetic discharge is causing an afferent arteriolar constriction. So what is afferent arteriolar constriction? So afferent arteriole breaks up into glomerular capillaries and this forms the efferent arteriole. Okay? And this is the Bowman's capsule. Okay? Now, if the afferent arteriole constricts, please remember there is a very important formula, and that is flow is directly proportional to the fourth power of radius. Have you understood? So if I constrict the afferent arteriole, I have less flow. Less flow means less hydrostatic pressure. What is hydrostatic? I told you it is a pressure due to a column of liquid. Less hydrostatic pressure means less PGC, less GFR. Okay? So never give up. Have you understood? Sympathetic? B, because sympathetic do constriction. C and D automatically incorrect. All right. Okay. All right. So I think you've got the concept. Okay, let's go on to the next one. A physiologist studies about the sensor which detects elevated sodium and decreases GFR. And in the given image of the juxtaglomerular apparatus, which of the following structure acts as the sensor? So juxtaglomerular apparatus has got three components. Number one is what is known as the JG cells. JG cells, these are in the tunica media of the afferent arteriole. These are renin secreting cells. They secrete renin. Second is the macula densa cells. Number two is what is known as the macula densa cells. Now, what are these macula densa cells? These are modified tubular epithelial cells. Modified tubular epithelial cells. At the beginning of DCT. And what are these? These macula densa cells act like a sensor. And what do they detect? They detect both sodium and chloride load in the tubular fluid, right? They detect both the sodium and the chloride load in the tubular fluid. Earlier knowledge was they detect only chloride load, but today we know they detect both sodium and chloride load in the tubular fluid. And number three is of course what are known as the lassus cells, right? Lassus cells. Role of lassus cells is not very well defined. So which is the sensor here? The cells which are marked by 1, beginning of DCT, modified tubular epithelial cells are, this is your answer, right? So again a high yield topic, JG cells, where are they located? Tunica media of afferent arteriole. What are they? Renin secreting cells. Macula densa cells, what are these? These are modified tubular epithelial cells. Where are they located? At beginning of DCT, end of loop of Henle and beginning of DCT. What is the role of the macula densa cells? They act like a sensor. They detect both sodium and chloride load in the tubular fluid. So more the sodium and chloride load in the tubular fluid detected by the macula densa cells, they in turn will cause an afferent arteriolar constriction to reduce the GFR. This is also known as the tubuloglomerular feedback. TGF. Tubuloglomerular feedback, or TGF, right? So let's see this. Tubuloglomerular feedback, a very brief revision of the tubuloglomerular feedback. Let's see that. More the GFR, more the sodium and the chloride load in the tubular fluid detected by the macula densa, which I just told you is a sensor which detects both sodium and chloride. There is more sodium and chloride reabsorption by the macula densa cells. Wherever sodium is absorbed, there is more sodium potassium ATPase activity. Increased breakdown of sodium generates adenosine. Adenosine acts on what are known as the A1 receptors on the macula densa cells. There is a release of calcium which causes constriction of the afferent arteriole and reduces GFR. So 2-3 important points here. Which is a sensor for the TGF? Macula densa. What does it detect? It detects both sodium and chloride. It is mediated by the TGF is mediated by adenosine. And what is the site of action of TGF? Tubuloglomerular feedback. It acts on the afferent arteriole, reduces the GFR. Is it okay? Has everybody got this? Yes, I can just move once again. Yes, this is your TGF. Important question, sensor, macula densa. What does it detect? Both sodium and chloride. What is TGF mediated by? Adenosine. Site of action is the afferent arteriole. What is the response? Decreases GFR. Is that clear? Got it? Okay. Let's go on to the next one. Which of the following is a correct statement? Right? Now, this is, please remember, clearance of inulin is equal to GFR. Clearance of inulin is equal to GFR. Right? Now, why inulin is equal to GFR? Because inulin is a substance which is freely filtered, not reabsorbed, not secreted. Right? This is because inulin is freely filtered, not reabsorbed, not secreted. So that means all reabsorbed substances, substances which are reabsorbed in the nephron, clearance of substances which are reabsorbed will be less than the clearance of inulin, and clearance of substances which are secreted will be more than the clearance of inulin. So this is an extremely important topic, and again, very important concept to understand. Firstly, what is clearance? Clearance of a substance is volume of plasma free of that substance in unit time. And what is the formula for clearance? Clearance is UV by P. Clearance of any substance is urinary concentration of that substance into V. V is rate of urine flow and P is plasma concentration of that substance. Again, this is a question which has been asked. What is U? U is the urinary concentration. What is V? This is rate of urine flow. And what is P? P is the plasma concentration. So one point that you have to always remember is concentration is always per unit volume. Rate is per unit time. So when I take urinary concentration, let's say in milligrams per ml, rate of urine flow is in ml per minute. Plasma concentration will also be milligram per ml. So both of these will get cancelled. So that means finally, what is the unit for clearance? ml per minute. Volume of plasma free of that substance in unit time. Remember, clearance of inulin equal to GFR. All reabsorbed substances will have a clearance which is lower than the clearance of inulin. All secreted substances will have a clearance which is higher than the clearance of inulin. So now you have three substances here: inulin, creatinine and urea. So if clearance of inulin is equal to GFR, urea is a substance which is freely filtered and partly reabsorbed. So urea clearance will be less than the clearance of inulin. Creatinine is a substance which is freely filtered and slightly secreted. So clearance of creatinine will be slightly more than the clearance of inulin. So once you have this in mind, now it becomes easy for us to answer. Inulin clearance is little more than creatinine clearance? No, in fact it is. Creatinine clearance is little more. Inulin clearance is little less. This is correct. Urea clearance is little more than creatinine? No, urea is less than both creatinine and inulin clearance. Same as creatinine clearance? No. So your answer to this question becomes B, right? And let's see this important graph here. So if this is the clearance of inulin, which is equal to GFR, which is 125 ml per minute. All reabsorbed substances will have a clearance which is lower than clearance of inulin. All secreted substances will have a clearance which is higher than clearance of inulin. This is the clearance of glucose. Urea clearance will also be somewhere here, below the clearance of inulin. This is clearance of creatinine. Creatinine is a substance which is freely filtered and slightly secreted. So its clearance is slightly more than the clearance of inulin. What is A is the clearance of para-aminohippuric acid. Remember, clearance of para-aminohippuric acid in low concentration is equal to the renal plasma flow. Right? Remember, para-aminohippuric acid is freely filtered and completely secreted. In low concentration. Right? So this is your clearance graph. Once again, clearance of inulin is equal to GFR. Inulin is a substance freely filtered, not reabsorbed, not secreted. All reabsorbed substances will have a clearance lower than the clearance of inulin. All secreted substances will have a clearance higher than the clearance of inulin. Clearance of para-aminohippuric acid in low concentration equal to renal plasma flow. In high concentration, the clearance reduces of para-aminohippuric acid. Why in low concentration? Para-aminohippuric acid has a very high clearance because it is freely filtered and completely secreted in low concentration. In fact, this graph has also been asked in your exam. Now, this was again from your exam. The question, the graph given below represents handling of which of the following substances by the glomerulus. Now, if you see this graph, it is showing you that the substance is freely filtered. Then after a particular point of time, the substance, like I said, is freely filtered here. Yes. Whatever is filtered is also reabsorbed, but the reabsorption shows you a maximum rate. Substance is getting freely filtered, but after a certain plasma concentration, whatever is filtered, it is not getting completely absorbed because there is something known as a Tmax. That means the reabsorption of the substance is a carrier-mediated reabsorption. Up to a certain plasma concentration, whatever is being filtered is completely reabsorbed. But after a certain plasma concentration, there is now an incomplete reabsorption. And so that substance begins to appear in the urine. Right? You see, this is what is excreted. Initially, there is zero excretion, nothing in urine. But then we find that the excreted substance, now there is the concentration of the substance in the urine increases. This is typically seen for glucose. Glucose has a Tmax, right? Glucose is, absorption of glucose is with the help of a carrier. And I told you right at the beginning of this discussion today that all carrier-mediated transports will have a transport maxima, a maximum rate of transport. Is that clear? Have you got this? This is a very typical graph, which is seen for, right. Now, what happens in the case of urea is, urea is a freely filtered substance. It is partly reabsorbed. Have you understood? Partly reabsorbed and then it is excreted, right? It is partly reabsorbed and excreted. So that means this particular graph which we are trying to show you here, that initially we find, again if you can just see this over here, initially whatever is being filtered, so this is the filtration graph here, this is the filtration graph here, line for filtration. This is the line for reabsorption. So whatever is being filtered is also reabsorbed, but after a certain point of time it reaches a Tmax. Whereas in the case of urea, it is partly, it's not completely reabsorbed, it's partly. So these two graphs will not coincide. You get my point? Have you got this? Yes, I thought somebody was asking me about urea. I'm not sure. I thought I saw a question. So remember, for urea is partly reabsorbed, right? But glucose below a certain plasma concentration is completely reabsorbed. So initially, both the filtration and the reabsorption graphs coincide with each other. It's only when glucose absorption reaches Tmax that the reabsorption graph will plateau out. Is that clear? Okay. All right, let's see the next question. A 60-year-old known case of diabetes mellitus has been noticed in laboratory workup to have microalbuminuria. What is the site of reabsorption of proteins in the ultrafiltrate? Remember, proteins are not freely filtered, but small amounts of proteins can be filtered, but they will all be reabsorbed in the proximal convoluted tubule, and generally by the process of endocytosis. Right? So this is your generally proteins, whatever small amounts of proteins which are filtered will be reabsorbed in the PCT. Principal site. Now these are extremely important questions which have been asked again and again in your exam. Principal site of absorption of sodium is which of the following? The most important site for absorption of all the electrolytes, whether it is sodium, whether it is potassium, whether it is chloride, bicarbonate, calcium, it's going to be the PCT, except magnesium. The site of maximum absorption of magnesium is the thick ascending limb, right? Sodium reabsorption in the PCT, how does it happen? This is with the help of a secondary active co-transport and secondary active counter-transport. This is a sodium-potassium ATPase pump on the basolateral membrane, and on the opposite side you have a co-transport, secondary active co-transport, which can be sodium glucose, sodium amino acid, sodium phosphate, sodium lactate co-transport, or it can be a secondary active counter-transport. Secondary active counter-transport is sodium H+. Yes, this is in the PCT. Then let's see sodium reabsorption in thick ascending limb. Thick ascending limb is again a secondary active co-transport. That is a sodium-potassium 2Cl- co-transporter. Right? Sodium-potassium 2Cl- co-transporter. This is the secondary active transport, which is a drug which acts on sodium-potassium, Na plus K plus 2Cl- co-transporter, Lasix. Loop diuretics. One point which I should have mentioned, sodium reabsorption in the PCT is 60%. Sodium reabsorption in the thick ascending limb is 30% by secondary active co-transport. A drug which acts on thick ascending limb, Lasix, loop diuretics. Sodium reabsorption in DCT is about 7%, and this is also with the help of a secondary active co-transport. And what is this co-transport? Sodium chloride co-transport. A drug which acts on sodium chloride co-transport, and that is thiazides. Maximum sodium absorption, PCT, secondary active co-transport and counter-transport. 30% of sodium absorbed in the thick ascending limb, secondary active co-transport. 7% of the DCT, again a co-transport. Okay, never give up says Na plus K plus 2Cl-, there is a syndrome which is known as the Bartter syndrome. Bartter syndrome affects the thick ascending limb. Symptoms are similar to Lasix overuse, right? That is Bartter syndrome. Absolutely right, never give up. In the DCT, what affects the Na is the Gitelman syndrome. Symptoms of Gitelman syndrome are similar to thiazide overuse. Get it? Never give up. Got it? Bartter syndrome, thick ascending limb, symptoms similar to Lasix overuse. In DCT, Gitelman syndrome, symptoms are similar to thiazide overuse. Excellent. Sodium reabsorption in late DCT and collecting duct, this is controlled by aldosterone. Aldosterone How is the absorption of sodium taking place in the DCT? This is epithelial sodium channels. Epithelial sodium channels. Sodium will move into the cell with the help of these epithelial sodium channels. A drug which is anti-aldosterone is spironolactone. And a drug which acts on the epithelial sodium channels, aldactone. Spironolactone is aldactone, sorry. This is amiloride. Amiloride. Excellent. Okay. Okay. All right. Let's go on to the next question. Sodium potassium chloride co-transporter Na plus K plus 2Cl minus co-transporter. I've just discussed it with you. This is a question which has been asked in your exam. Thick ascending limb. Next question, sodium chloride co-transporter. Na plus Cl minus co-transporter. This is present in the DCT. Again, a question from your exam. If a person starts consuming more sodium suddenly, which of the following is the correct statement? More the intake of sodium, more will be the excretion of sodium. Yes, the kidneys will help to maintain. One of the most important functions of the kidneys is to maintain the sodium balance. Yes, sodium balance. So this is your more the intake, more will be the excretion of sodium. Potassium. Potassium is maximally absorbed in which of the following segments? PCT again. I told you sodium, potassium, calcium, all from PCT. Bicarbonate, chloride, PCT. The only ion which is maximally absorbed in the thick ascending limb is magnesium. Okay, let's go on to the next one. Maximum water absorption is also going to be the PCT. 65%, 2/3 of the water is absorbed in the PCT, right? So this is, but remember ADH controls the water reabsorption in the collecting duct, right? But maximum water absorption, whether ADH is high or low, will always be in the PCT. Okay? Patient with ABG. Now this is interesting. Patient of ABG, pH is 7.28, bicarbonate 28, PCO2 60. So this is, remember, room. Respiratory, opposite. Metabolic, equal. In respiratory, more the pH, less the PCO2. Less the pH, more PCO2. In metabolic, more the pH, more bicarbonate. Less the pH, less bicarbonate. It is equal, right? So here you find that the pH is lower, PCO2 is higher, less pH, more PCO2. So this becomes a respiratory acidosis. Whenever you have to comment on a respiratory, you see how do you comment on acidosis or alkalosis? Look at the pH, look at the PCO2, look at the bicarbonate. Normal pH 7.4, normal bicarbonate approximately 24 to 25. CO2 should be 40, right? So here you have a lower pH and a higher PCO2, room, respiratory, opposite, metabolic, equal. So look at here, the pH is low, but the PCO2 is higher. So this is a respiratory cause of acidosis. In metabolic, look at the pH and the bicarbonate levels. In metabolic, equal. Higher the pH, higher bicarbonate, lower pH, lower bicarbonate. Right. Absolutely right. Never give up. You are absolutely clear with your concept. Fantastic. Let's look at the next one. A researcher studying the phases of ventricular muscle action potential is shown below. Which phase represents the closing of fast sodium channels? Remember, there are 5 phases of the cardiac plateau potential. This is known as the plateau potential. So 5 phases are phase 0, phase 1, phase 2, phase 3, phase 4. 5 phases. And what are the reasons for these phases? Phase 0 is depolarization, which is because of a sodium influx through voltage-gated sodium channels. Phase 1 is early repolarization. This is because of closure of the sodium channels and a decrease in sodium influx. Phase 2, which is the plateau phase, this is due to a calcium influx through what are known as slow calcium channels. Slow calcium channels, plus there is also a potassium efflux. When the calcium channels close, then in phase 3, which is late repolarization, only a potassium efflux. So, my question was, what is phase 1 due to? Right? So phase 1 will be due to closure of the fast sodium channels. Right? So answer to this question is C. Once again, phase 0 depolarization because of opening of voltage-gated sodium channels and sodium influx. Phase 1 is early repolarization due to closure of sodium. Phase 2 is plateau phase. This is because in phase 2 there is movement of calcium from outside to inside and potassium from inside to out. Gain of positive charge and loss of positive charge. So no change in potential. At the arrow, calcium channels will close. Phase 3, which is late repolarization, is due to only a potassium efflux. Right? So this is your plateau potential. Okay? Again, a high yield and important topic. Next question. Which of the following phases of cardiac cycle corresponds with the first heart sound? First heart sound is onset of ventricular systole. And which is the first phase of ventricular systole? Isovolumetric contraction phase. Then the second phase is isovolumetric contraction phase. Then you have the phase of rapid ejection and a phase of slow ejection. Right? So first heart sound, which is the onset of ventricular systole due to closure of the mitral and tricuspid valves, due to closure of the atrioventricular valves, closure of AV valves, atrioventricular valves, mitral valve on the left side, tricuspid valve on the right side. Right? So this will be heard at the onset of isovolumetric contraction phase. S2 is end of systole, beginning of diastole. Right? So this is S1 is at the onset of ventricular systole. This is due to closure of the AV valves. Onset of isovolumetric contraction phase, which is the first phase of ventricular systole. Next, which of the following is correct about the jugular venous pulse? Again, a important topic. The JVP is seen on the right side. Why on the right side? Because the right internal jugular vein is in direct communication with the right atrium. So whatever the right atrial pressure changes will be reflected in the JVP, right? And JVP, do you measure it from the xiphisternum? No. Xiphisternum is the lowermost part of the sternum. Where do you measure it? You measure it from the angle of Louis. V wave is just one second, please. Sorry, I need to. I've lost connection with YouTube, so let me just see here. Yeah, V wave is sorry. All right. So, is it measured from the Xiphisternum? No, it is measured from the angle of Louis. Now, V wave. So it has got three positive waves, A wave, A, C, V. A is due to atrial contraction. C is in isovolumetric contraction phase. This is due to bulging of the closed tricuspid valve into the right atrium during isovolumetric contraction. Yes? And V is due to venous filling just before opening of the tricuspid valve. So V wave occurs in isovolumetric contraction. That is not true. What you get in isovolumetric contraction phase is the C wave. Upper level of JVP rises with deep inspiration? No, it falls with deep inspiration. Y descent occurs in the rapid ventricular filling phase, which is true. Y descent is a negative wave. There are two negative waves, X descent and Y descent. X descent is in the ejection phase, and Y descent is in the first rapid filling phase. So answer to this question becomes D. Excellent. All right. Okay, so let's go on to the next question. Large V wave on the JVP will be seen in which of the following conditions? Remember, what is V wave due to? V wave is due to venous filling of the right atrium just before opening of the tricuspid valve. Yes? So if you look at this, I'm just showing you the right side of heart. This is the right atrium, this is the right ventricle. When blood comes from the right atrium, from the superior and inferior vena cavas, fills up the right atrium, there is what it gives rise to a positive wave, which is called the V wave. Now, a large V wave will be seen, that means there is more atrial filling, and that happens in what is known as tricuspid regurgitation. What happens in tricuspid regurgitation? In tricuspid regurgitation, the tricuspid valve is incompetent. So the filling of the right atrium is not only from the superior and inferior vena cavas, but also from the right ventricle. So you get a very large V wave in blood goes back into the right atrium. Absolutely right. Never give up. Absolutely right. Okay. So tricuspid regurgitation. Yes, a large V wave will be seen in tricuspid regurgitation. Okay. So once again, A wave atrial systole in the second rapid filling phase. C wave is in the isovolumetric contraction phase. X descent is in the ejection phase. V wave is in the due to venous filling of the right atrium just before opening of the tricuspid valve. Y descent is seen in the first rapid filling phase. Right? First rapid filling phase. Excellent. Okay, the pressure volume curve is shifted to the left in which of the following conditions? Now, this should have been actually pressure volume loop. So just a brief recap of the pressure volume loop. Pressure volume loop, left ventricular volume is on the x-axis, pressure is on the y-axis. Volume of the left ventricle varies between 50 and 120. Pressure from 0 to 120 millimeters of mercury. End of diastole, left ventricular volume is 120, pressure is 5, this is point A. At point A, left ventricular pressure is higher than the left atrial pressure. Mitral valve closes, gives rise to the first heart sound. Right? If you can see this here, left side of heart only. This is left atrium, left ventricle, aortic valve is closed. When the left ventricular pressure is more than the left atrial pressure at the end of the filling phase, mitral valve closes, first heart sound, onset of systole. Now, A to B, there is a sharp increase in the LV pressure with no change in volume. A to B is isovolumetric contraction phase. At point B coincides with diastolic blood pressure. At point B, the aortic valve opens. Now starts the phase of ejection. There is a rapid and a slow ejection phase till it reaches point C. So this is your ejection phase. B to C is ejection phase. At point C, the aortic valve closes, producing the second heart sound, end of systole. Now you have the isovolumetric relaxation phase. Sharp fall in pressure with no change in volume till it reaches point D. At point D, the mitral valve opens, and now you get the phase of filling. A is S1, C is S2. Between A and C is systole. A to B is isovolumetric contraction, sharp increase in LV pressure with no change in volume. At point B, aortic valve opens and there is a phase of ejection. Blood will go from the left ventricle into the aorta. Rapid ejection, then slow ejection. At the end of the ejection phase, the aortic valve closes. When the aortic valve closes, you get the second heart sound, end of systole. Between C and D is isovolumetric relaxation, sharp fall in pressure with no change in volume. At point D, now the mitral valve opens. Mitral valve opens and you get the filling phase. At A, the mitral valve closes and the whole cycle repeats. Which valve closes, opens and closes at which point? Remember, physio ma'am, Coco. At point A, mitral valve closes, producing the first heart sound. At point B, aortic valve opens. At point C, aortic valve closes, producing the second heart sound. And at point D, mitral valve opens. So this is your ma'am Coco, right? Okay, so let's see what happens in different valvular conditions in the, remember, width of the loop. Width of this loop is equal to the stroke volume. Right? Width of the loop is, what is stroke volume? Volume of blood ejected per ventricle per beat. Right? So let's see, tall and narrow loop. Now, tall and narrow loop means stroke volume is less. That is why it is narrow. Tall, that means it is exerting more pressure. This is typically going to be seen in aortic stenosis. If the aortic valve is not opening properly, left ventricle has to exert much more pressure to push the blood. So it is a tall and a narrow loop. All stenotic conditions will be narrow loops. Regurgitant lesions, wider loops. So let's see the next one. In mitral, now this is mitral stenosis. Now here the mitral valve is stenosed. If mitral valve is not opening properly, that means there is less filling of the ventricle. Less filling means less stroke volume. So it is a narrow loop, less stroke volume, and the loop has shifted to the left. Why? Because there is less filling. There is a decrease in the end diastolic volume. So shift of the loop to the left. Let's see a regurgitant lesion. Now this is wide loops, so large increase in stroke volume. Now this is typically seen in aortic regurgitation, and a wide loop is also seen in a mitral regurgitation. This is seen in typically mitral regurgitation. To distinguish between aortic and mitral regurgitation, you have to look at the isovolumetric relaxation. In aortic regurgitation, you can see that the isovolumetric relaxation is not a straight line, it is tilting to the right. Right? Here. So there is an increase in the left ventricular volume during isovolumetric relaxation. It is not a straight line. Remember, in isovolumetric relaxation, there should be no change in the LV volume. But here there is an increase in the LV volume in isovolumetric relaxation. This is because of aortic regurgitation, not difficult to understand. Aortic valve does not close properly, so blood will regurgitate back into the left ventricle during the isovolumetric relaxation phase. So a rightward tilt will be is your aortic regurgitation, right? You do not see this in mitral regurgitation, you will see this in aortic regurgitation. Clear? So once again, all these 4 loops: tall and narrow loop, aortic stenosis; shift of the loop to the left, mitral stenosis; wide loops, regurgitant lesions; wide loop with right tilt of the isovolumetric relaxation phase, aortic regurgitation; and a wide loop with no such tilt, mitral regurgitation. Clear? Okay. So answer to this question is pretty simple, and that is shift of the loop to the left will be seen in mitral stenosis. Okay. Let's go on to the next one. This is a question from your exam. Pressure volume graph of cardiac hemodynamics. What does point B mean? So remember your ma'am Coco. Point A, mitral valve closes. Point B, aortic valve opens. So opening, I think they've missed out. So let me write it as opening of aortic valve. So A is the answer. C is aortic valve closes. D is mitral valve opens, right? So opening of mitral valve at point D, closing of aortic valve at B, closing of mitral valve is at point A, and opening of aortic valve is at point B. Ma'am Coco, right? A, mitral valve closes, first heart sound. At point B, aortic valve opens. At point C, aortic valve closes, second heart sound. At point D, mitral valve opens. Absolutely right. Okay. The hormone involved in the regulation of blood pressure is which of the following? This should not be a problem. This is angiotensin II, the renin-angiotensin-aldosterone mechanism. This is a very important regulator of blood pressure, right? This is your angiotensin. Angiotensin II is a very powerful vasoconstrictor. What are the actions of angiotensin II? It causes vasoconstriction, increases the total peripheral resistance, and increases the blood pressure. It also decreases GFR. It also increases thirst. It increases aldosterone, which in turn increases sodium reabsorption, retention. Angiotensin II, excellent. We know that renin will act on angiotensinogen, convert it into angiotensin 1. Angiotensin 1 is converted by the ACE enzymes to angiotensin 2. Angiotensin 2 will cause an increase in blood pressure. It also causes secretion of aldosterone, which causes sodium and water retention. Ultimately, blood pressure is going to be increased. Remember, what is the most important stimulus for release of renin? Fall in blood pressure, loss of blood volume, hypotension, hemorrhage, hypovolemia. These are will cause increased secretion of renin, right? Hypovolemia, hemorrhage. hypotension, hyponatremia, these will increase renin, and renin in turn will cause generation of angiotensin II, which will elevate the blood pressure and try to bring it back to normal. Oh, how thirst, kindly explain. Okay, so what happens is angiotensin II, this acts on SFO. SFO is subfornicial organ. This is an area in the brain, which in turn sends impulses to the lateral hypothalamus. Lateral hypothalamus is the thirst center, and then it increases thirst. Have you understood? So hemorrhage, patients who've lost blood complain of thirst, right? So this is and a common example, at least older movies, I normally give this example. You remember Sholay or somewhere, one of the old movies, if you've ever seen them. The hero gets shot, he loses blood, and he starts asking for pani, right? So hemorrhage is associated with thirst. So this is the mechanism. Angiotensin II will act on SFO, which in turn sends excitatory impulses to the lateral hypothalamus. Lateral hypothalamus is the thirst center. So such patients will complain of thirst. Is it okay? Varun Kashyap? Okay. Arrange the following in the right order. This was again a question from your exam, which is one is the aortic area on the right side of the sternum, second intercostal space. 2 is the pulmonary area on the left side, second intercostal space. 3 is the tricuspid area on the left side in the fourth intercostal space, and number 4 is mitral area in the fifth intercostal space in the mid-clavicular line. So these are your right? Okay. Are you okay with that? See, so Never Give Up says, yes, I watch old movies in lunchtime. Good. And Varun Kashyap says, should we give water to trauma patients? No. I'll tell you why we avoid water, because we do not know what is the reason for trauma. Maybe this patient has to be taken up for surgery. Yes? If the patient is taken up for surgery, then you need to keep him nil orally. So normally we do not give water because of that, isn't it? But otherwise, or I don't know, you must have noticed this small, there's birds which get injured. We try to give them water, no? Because they also feel thirsty if they've lost blood. I don't know if you've ever done that. Yes? If you've seen one unfortunate bird or an animal which has got injured, lost blood, we generally give them water because they will be thirsty. But patients we don't, because obviously probably the patient has to be taken up for surgery, so you have to keep him nil orally. Right? Okay. If the diameter of an artery was found to be reduced by 1/3, by what value does the resistance of the artery increase? Now remember, resistance is inverse to the 4th power of radius. More the radius, less the resistance. Less the radius, more the resistance. Now it says the radius has become 1/3. Right? So now the resistance will increase by how many times? 3 into 3 into 3 into 3. So what is that? 3 into 3 is 9, 9 3s are 27, 27 3s is 81. So my answer to this question is 81 times. Again, this is a question from your exam. All right. So what is the Ohm's law? 2 important laws of hemodynamics which I must revise with you. Ohm's law states that flow through a tube is directly proportional to the pressure difference at the 2 ends of the tube, directly proportional to P1 minus P2 and inverse to the resistance to flow. Flow is equal to delta P by R. Hagen-Poiseuille's law states that resistance is equal to A tan eta L over pi r4. What is neta? This is viscosity. More the blood viscosity, more the resistance. L is length and small r is radius. So I have already discussed with you that resistance is inverse to the 4th power of radius. Okay? So this should not be a problem. Let's see the next one. Dopamine in low doses acts as which of the following? Dopamine in low dose. So the action of dopamine is going to be different in low, intermediate and high dose. So in low dose, it is a vasodilator. If it's a vasodilator, it will increase the GFR. Right? So let's see this. Let's see this. This is actually more pharmacology than physiology, but we can do that. Dopamine in low infusion rate causes vasodilation, including the kidneys, increasing GFR. Intermediate infusion stimulates myocardial contractility, increases electrical cardiac conductivity and increases the cardiac output. But dopamine in high doses is vasoconstriction. It increases the BP via adrenergic receptors. So dopamine has got these multiple actions. Low dose vasodilator, intermediate dose more cardiac effects, cardiac contractility, electrical conductivity and increases cardiac output. But in high doses, this causes a vasoconstriction and increases blood pressure. You know that you give dopamine infusion in patients with shock, isn't it? It's one of your pressor agents which is used. So Varun Kashyap says, explain the Bernoulli's. Okay. Where can I explain Bernoulli's to you? Let me try and explain it here. Okay. So this is nothing to do with dopamine. I'm just explaining. So I'm taking a little part here to explain Bernoulli's. So Bernoulli's is that if you remember your Bernoulli's equation, it says total energy is equal to kinetic energy plus potential energy. And we can use this concept to blood flow. So total energy of flow is equal to kinetic energy of flow plus the potential energy. What is the potential energy of flow? This is potential, and this is the lateral pressure exerted on the walls of a blood vessel. Have you understood? So total energy of any system remains constant, right? Total energy is equal to kinetic plus potential energy, and we can use it for blood flow through a tube. Yes? So let's try and understand this. Now supposing there is a narrowing in a blood vessel, right? So what will happen now? As the blood flows through the narrowed segment, there is an increase in the kinetic energy and a decrease in the potential energy. Total energy has to remain constant. As the blood goes through this constricted part of the vessel, kinetic energy of flow increases because the velocity of flow increases. So more velocity, more kinetic energy, lateral pressure exerted on the vessel wall will reduce. So what is the clinical application here? Clinical application is that if there is a constriction in a blood vessel, the flow of blood cannot remove the constriction. Constriction stays, Q, because the lateral pressure which is exerted reduces. But if there is a, let's say, an aneurysm. Let's see. Here is an aneurysm. Okay? Now when blood goes through a part of the vessel where there is an aneurysm, velocity reduces because radius is increasing, right? So there is a decrease in velocity. So there is a decrease in kinetic energy, but there will be now, therefore, an increase in potential energy. So lateral pressure exerted on the walls will increase. So aneurysm keeps on dilating. That is why you have aneurysmal ruptures. But a constriction remains. The flow of blood is not able to remove a constriction. Narrowing of a vessel probably worsens. But aneurysmal dilatation keeps on increasing. This is the concept of Bernoulli's. Is that okay? Varun? Varun Kashyap, have you understood what Bernoulli is? Okay, next let's see. Go on to respiratory. Okay? Are you okay with me taking about half an hour more? Is that okay? Right? These are all such important high-yield topics. Let me just take it for half an hour more. All right. A 60-year-old patient complains of breathlessness on climbing stairs, on auscultation. Okay. On auscultation, heart sounds are normal and normal breath sounds are heard in bilateral fields. Flow volume loop is as shown here. Now, which is this diagnosis? Now here, the flow volume loop, this is, remember, for obstructive lung disease, the shape of the loop is like this. Two important lung diseases. The shape of the loop is, I'll just make this once again. This is a scooped out curve. This is an obstructive lung disease like bronchial asthma. Whereas this curve, which is a tall and a relatively narrow curve, this is in restrictive lung disease. So my answer to this question is going to be parenchymal restrictive lung disease. Please remember, in an obstructive lung disease, the shape of the curve is scooped out. Early collapse of airways causes a scooped out curve. But restrictive lung disease, it's a relatively taller and a narrower curve. So this is seen in restrictive lung disease. So this is important, again, image-based question from your exam. Okay, left shift of the oxygen dissociation curve is seen in which of the following? Increase in temperature causes a right shift. Increased 2,3 BPG, right shift. Increased H plus or decreased pH will be right shift, but increased pH is a left shift. Increased PCO2, right shift. So my answer to this question is C. Okay? Okay. Right shift of the curve is going to be seen if there is increase in PCO2, increase in H plus, decrease in pH, increase in temperature, increase in 2,3 BPG and hemoglobin S. Left shift is opposite, decrease in PCO2, decrease in H plus, increase in pH, decrease in temperature, decrease in 2,3 BPG, hemoglobin F and myoglobin. So these are important, again, a high yield, all of these which I'm discussing with you are high yield topics. So please focus on them, please do them, please revise them, and I'm sure most of your questions will come from here. Now, increase in 2,3 BPG. 2,3 BPG is a byproduct of glycolytic pathway, and this is GITA, growth hormone, exercise, thyroid hormone, anemia, high altitude, and excess of androgens. These are the conditions which will cause increase in 2,3 BPG. Whenever there is excessive growth hormone, exercise, excessive thyroid hormone, anemia, high altitude and androgens. And remember, more 2,3 BPG, less binding with oxygen. Shift of the curve to the right. Remember, FDR favors delivery, shift to right. FAL favors affinity, shift to left. Rightward shift means increase in P50, decrease affinity, more delivery. Favors delivery, shift to right. FAL, leftward shift means decrease in P50, increased affinity, increased association. Right? So more association, shift to left. And rightward shift is a less affinity, more delivery. Is that clear? Never give up. I didn't understand your question. HBF has more. Okay. All right. So these are the conditions which will cause a rightward shift and a leftward shift. Again, a very, very high yield topic. Okay. Next. Which of the following is correct about CO2 dissociation curve, which is shown over here? This is your Haldane effect. Haldane effect. Haldane effect is, this is for CO2 transport. This says deoxyhemoglobin can bind more CO2 than oxyhemoglobin. This is deoxyhemoglobin. Venous blood has deoxyhemoglobin binding more CO2, and oxyhemoglobin is arterial blood, which binds less CO2. Makes a lot of sense. Deoxyhemoglobin is formed when the blood reaches the tissue capillaries. Yes, deoxyhemoglobin, so it can bind more CO2. So tissue capillaries, the hemoglobin will be deoxy, it binds more CO2. When the blood reaches the pulmonary capillaries, oxyhemoglobin is formed, less binding with CO2. So CO2 is excreted. So this is what is known as your CO2 dissociation curve. Why do we call it CO2 dissociation curve? You have partial pressure of CO2 on the x-axis and the CO2 content is given on the y-axis. Right? So this is telling you that in more the oxygenation, less CO2 binding, less the oxygenation, more CO2 binding. Okay. Okay. In gestational life, surfactant is produced by which of the following cells? Surfactant will be produced by the type 2 pneumocytes. What are the type 1 pneumocytes? Type 1 pneumocytes are involved in respiratory exchange. These are flat cells. These are the type 1 pneumocytes which are in respiratory exchange. This is type 2, smaller cells, and these are type 1. Type 1 is meant for exchange of oxygen and CO2. Right? Surfactant is produced by type 2 pneumocytes. Role of surfactant? To lower the surface tension. Respiratory distress syndrome is due to defective type 2 pneumocytes. Defective surfactant secretion. Surfactant lowers surface tension. So here the commonest reason is, like I said, lack of surfactant. Okay. Carotid body chemoreceptors are stimulated by all the following types of hypoxia except carotid body chemoreceptors will be stimulated only by all types of hypoxia except the anemic hypoxia. So let's have a look at the types of hypoxia. How do you diagnose them? Whether there is going to be a peripheral chemoreceptor stimulation. Now the first is what is known as hypoxic hypoxia. Hypoxic hypoxia is what is seen in high altitude, or let's say if there is hypoventilation due to any cause. Something has happened and there is hypoventilation. Maybe there is a respiratory muscle paralysis. Maybe there is a bulbar infarct. There is an infarct in the medulla which reduces movement of the respiratory muscles, so hypoventilation. So here this is characterized by decreased PO2 and decreased saturation. What is PO2? Partial pressure of oxygen. This refers to the dissolved oxygen. What is SO2? Saturation. This is the saturation of hemoglobin with oxygen. This is a percentage. Peripheral chemoreceptors present? Yes, because a low PO2 will stimulate the peripheral chemoreceptors. A low PO2 is one of the most important stimuli for peripheral chemoreceptors. And peripheral chemoreceptors, if they are stimulated, there is an increase in the rate and increase in the depth of ventilation. Yes? And this is what happens. Supposing, let's say, tomorrow you go for a holiday to Leh Ladakh. The first thing which happens is there is hypoxia. And so what happens to your breathing pattern? deep and faster respiration. Have you understood? So that is because the peripheral chemoreceptors will be stimulated. Second is anemic hypoxia. Anemic hypoxia is seen in, let's say, iron deficiency anemia or a hemolytic anemia. What will happen over here? There is a decrease in hemoglobin, but saturation of that hemoglobin is normal. PO2 is also normal, right? So no peripheral chemoreceptor stimulation. Absolutely right, never give up. There is anemia, anemic because it depends on the dissolved hemoglobin. Not dissolved hemoglobin, dissolved oxygen, right? So dissolved oxygen is normal, so therefore no stimulation of peripheral chemoreceptors. Okay, so Varun says it causes tachypnea. No, tachypnea is increase only in rate. There is increase in rate and depth, which is known as hyperventilation. Have you understood? Tachypnea is only an increase in rate, right? The third type is what is known as stagnant hypoxia. Stagnant hypoxia is seen in cardiac failure. Now, in stagnant hypoxia, there is an increase in the arteriovenous oxygen difference. Peripheral chemoreceptor stimulation will be present. Then the fourth is histotoxic hypoxia. Histotoxic hypoxia is, for instance, cyanide poisoning. Here the tissues are unable to utilize oxygen. So there is a decrease in the arteriovenous oxygen difference. Remember, cyanide is an agent which directly stimulates the peripheral chemoreceptors. So peripheral chemoreceptor stimulation will be seen in histotoxic hypoxia. The only type of hypoxia where no peripheral chemoreceptor stimulation is seen is your anemic hypoxia. Right? So simple question, anemic hypoxia. Okay. What is the affinity of carbon monoxide to hemoglobin in comparison to oxygen and hemoglobin? 210 times. 210 times. Yes. Absolutely right. Never give up. Cyanide will block the ETC complex, so tissues will be unable to utilize oxygen. So venous O2 will increase. Or in other words, there is a decrease in the arteriovenous oxygen difference. What is the affinity of carbon monoxide to hemoglobin? 210 times. Yes, carboxyhemoglobin. Absolutely right, never give up. Yes, and what is the type of poisoning in what is the type of hypoxia in carbon monoxide poisoning? This is anemic hypoxia. Okay. Okay, Varun Kashyap says neural control. I'll just explain that to you. I don't have a free slide to do it. Okay, I'll just do it for you. A person hiking on mountain experiences breathlessness. Which of the following is a probable reason? He goes to a high altitude area. There is lower PO2 in the atmosphere that stimulates the, there is a decrease in PO2 which stimulates the peripheral chemoreceptors. And that in turn causes an increase in the rate and increase in the depth of ventilation. So he now starts breathing that like I told you, like that. So that is your breathlessness which he experiences. This is because of the hypoxia. Okay. Regarding respiratory adjustments seen during exercise, what happens in exercise again? There is an increase in the rate and depth of ventilation. Depth of ventilation, but this is not because of a decrease in PO2, right? This is because of the joint proprioceptors. When you exercise, your joint proprioceptors send impulses to the respiratory center in the medulla, and they increase the rate and depth of ventilation, right? So this is a very important point, and that is, it is the joint proprioceptors. In fact, even before you start the exercise, The joint proprioceptors will increase the cardiovascular as well as the ventilatory response. This is, like I told you, what is known as the effect of joint proprioceptors on the respiratory center. Okay. Which of the following is involved as a second messenger in the mechanism of gastric acid secretion? Now, second messenger here, the answer is cyclic AMP. So, if I look at a parietal cell secretes H plus HCl. It has an H plus K plus ATPase pump, which is also known as your proton pump, isn't it? For all conditions associated with increased acid output, we use proton pump inhibitors. So H plus K plus ATPase. Now, what can cause an increase in the activity of H plus K plus ATPase? Number one is gastrin. Gastrin will act on its receptors. The receptors for gastrin on the parietal cells are CCK2 receptors. Second messenger here is inositol triphosphate and calcium, which increase the activity of protein kinases and which increase the activity of H plus K plus ATPase, increase the acid output. Two important points. Receptor for gastrin on parietal cell, CCKB or CCK2. Second messenger, inositol triphosphate and calcium. Second is gastrin can also increase histamine. Histamine will act on H2 receptors. Second messenger, cyclic AMP, increases output of acid. Right? Acetylcholine will act on its muscarinic receptors. Second messenger, inositol triphosphate and calcium, and increase the output of acid. So which are the second messengers here? Cyclic AMP, inositol triphosphate and calcium. Since inositol triphosphate is not given, so my answer here is cyclic AMP. CCKB is a receptor. It's not the second messenger. Right? Second messengers are cyclic AMP, inositol triphosphate. So as you can see over here, I've already told you about the H plus K plus ATPase and the cellular control. Also have discussed gastrin acts on CCK2 receptors. Second messenger, inositol triphosphate and calcium. Histamine acts on H2 receptors. Second messenger, cyclic AMP. The acetylcholine acts on muscarinic receptors, M3, inositol triphosphate and calcium, which will increase the output of acid. Okay. Which of the following statements is correct regarding secretin? Secretin is secreted by the S cells in the duodenum. And secretin will increase the bicarbonate content in bile and in pancreatic juice. Right? It basically makes the bile and the pancreatic secretion alkaline, which is so important because as food comes, as the gastric chyme comes into the duodenum, gastric chyme is acidic. Duodenal walls, the walls of small intestine do not have barriers. So you need to reduce the acidity of the gastric chyme by making the bile and pancreatic juice alkaline, and this is done by secretin, S cells in the duodenum. Where does the digestion of disaccharides take place? Now, disaccharides will be digested by the disaccharidases, which are present in the brush border of the small intestine. See, carbohydrate digestion, there is a salivary amylase, then no carbohydrate digestion in the stomach, then in the oral cavity, salivary amylase, stomach, there is no digestion of carbohydrates. Then in the small intestine, then the pancreatic secretions has the pancreatic amylase. And the intestinal epithelial cells will secrete disaccharidases like lactase, maltase, sucrase, right? Sorry, intestinal epithelial cells will secrete the disaccharidases. So this should not be a problem. Yes? Let's have a look at the next one. Identify the event taking place in the small intestine. This is trying to show you segmentation contractions. Yes? In a segment of intestine, this is a segment of intestine, there are alternate contraction and relaxation. Alternate contraction and relaxation in a segment of intestine, and so this is known as segmentation contractions. And what are these segmentation contractions? These are mixing contractions. What is peristalsis? Peristalsis is meant for a forward propulsion of food. Forward propulsion of food. This is segmentation contractions. Let's see the next one. Which pancreatic neuroendocrine tumor causes recurrent episodes of secretory diarrhea? This is a VIPoma, recurrent episodes of secretory diarrhea, right? And VIP, what are the actions of VIP? VIP, very importantly, it causes myocardial contractility, glycogenolysis, decreases HCl secretion in the stomach, vasodilation, lowers blood pressure, relaxation of smooth muscle. So that is your VIP. Now, what is a VIPoma? 90% arise from the pancreas. A VIPoma has a triad: diarrhea, hypokalemia, hypochlorhydria, or achlorhydria. So this is a very important syndrome, VIPoma, yes, and watery diarrhea, hypokalemia, and hypochlorhydria or achlorhydria. Here the stools are odorless, colorless, large volumes, yes, and the important point, sorry, not colorless, they are tea-colored, sorry, typically tea-colored and odorless. Unlike an infective diarrhea where there will be strong odors which are present. These are tea-colored and odorless. Okay. Which of the following would help in explaining the mechanism of action of ANP? ANP is the only hormone which uses cyclic GMP as a second messenger, right? Second messengers become extremely important high yield points. Cyclic AMP is a second messenger for hypothalamic hormones, CRH and somatostatin. For anterior pituitary hormones, except growth hormone and prolactin. Except for these two, all other anterior pituitary hormones, cyclic AMP is a second messenger. ADH, V2, glucagon has been asked as a question. Catecholamines, beta adrenergic response has been asked as a question. Both the hormones involved in calcium metabolism will use cyclic AMP as a second messenger, and angiotensin II also uses cyclic AMP. So extremely important table. Hypothalamic hormones, CRH and somatostatin, all anterior pituitary hormones except growth hormone and prolactin. ADH is a posterior pituitary hormone, uses cyclic AMP as a second messenger. Glucagon for glucose metabolism, cyclic AMP. Catecholamines, beta adrenergic response, cyclic AMP. Both the hormones involved in calcium metabolism, parathormone and calcitonin, and angiotensin II. Cyclic GMP easy, atrial natriuretic peptide and brain natriuretic peptide. Hormones using phospholipase as a second messenger, yes. Hypothalamic hormones, TRH, GHRH, GnRH. Yes. CRH and somatostatin were cyclic AMP. ADH, V1 and V3. Posterior pituitary hormone, oxytocin. ADH, V2 was cyclic AMP. Catecholamines, alpha receptors is phospholipase, inositol triphosphate. Hormones which do not need second messenger, extremely important, has been asked. Growth hormone, IGF-1, prolactin, leptin, insulin. Insulin does not need a second messenger because insulin receptor itself has tyrosine kinase activity. Growth hormone, IGF, prolactin and leptin, they act via the JAK-STAT pathway. JAK-STAT pathway. Right. Which of the following hormones can regulate release of prolactin from the anterior pituitary? TRH. In hypothyroidism, there is increase in TRH, which increases prolactin secretion. Very commonly, a patient presenting with galactorrhea. What is galactorrhea? Milk secretion from the breast. So before you tell the patient that you have a prolactinoma, a prolactin secreting tumor, first get the thyroid profile done. It could be a simple case of hypothyroidism. In hypothyroidism, there is going to be increase in TRH, and TRH can increase the prolactin secretion. So such patients will present with galactorrhea. One of the commonest ways in which hypothyroidism can present is with galactorrhea. A patient with a known brain tumor learns that his pituitary stalk has been affected. Secretion of which of the following hormones would likely to be increased after sectioning of the pituitary stalk? All hormones of the anterior and posterior pituitary will be reduced except prolactin. Why? Because secretion of prolactin is reduced by prolactin inhibiting factor from the hypothalamus. All other hormones will reduce if the connection between hypothalamus and the pituitary is lost. So all of these will reduce except prolactin. Prolactin will increase because prolactin is controlled by prolactin inhibiting factor. All the others are controlled by releasing hormones. This is controlled by inhibiting factor. What is prolactin inhibiting factor? Nothing but dopamine, right? Remove inhibition, remove inhibitory control. What will happen to the hormone? Increases, right? Okay, coming almost to the end of our discussion. Which of the following hormone is involved in the milk ejection or milk letdown? This has to be oxytocin. Oxytocin causes contraction of the myoepithelial cells around the ducts, and this in turn causes the milk letdown. Which of the following is correct regarding oxytocin? It is responsible for galactokinesis, which is true. It is secreted, it can be given by the oral route. No, it is secreted by the posterior pituitary, not by the anterior pituitary. And this is also incorrect. Okay, let's go on to the next one. Actions of prolactin and oxytocin. Oxytocin causes milk letdown, whereas prolactin will increase the synthesis of milk proteins like casein and lactalbumin and increases the milk synthesis and secretion. Oxytocin, contraction of the myoepithelial cells, milk letdown. Prolactin increases synthesis of milk proteins and thereby increases secretion. Thyroxine has a maximum affinity for which of the following? The binding proteins for thyroid hormones are TBG, albumin, and transthyretin. Transthyretin was earlier known as thyroid binding prealbumin. Now we call it transthyretin. T4 has maximum affinity for TBG. T3 has maximum affinity for albumin. So my answer to this question will be thyroxine binding globulin. Right? Okay. Which of the following hormones is produced by the cells indicated in the adjoining? Now this is trying to show you the thyroid gland. The cells indicated are the follicular cells, and follicular cells will secrete thyroid. Parafollicular cells secrete calcitonin. But the follicular cells will secrete thyroid. So if you can look at this diagram here, follicular cells which line the follicle, thyroid secreting cells, these are your parafollicular cells, which are these are your parafollicular cells, if you can make out. They are parafollicular, next to the follicles. They will secrete calcitonin. Again, a question which has been asked again and again. That is, calcitonin is secreted by the C cells in the thyroid gland. Source of calcitonin is thyroid gland. Parathormone, of course, from the parathyroid gland. Yes, a 35-year-old lady is diagnosed with Hashimoto's. In Hashimoto's, antibodies are against the thyroid peroxidase enzyme. Thyroid peroxidase regulates all the steps involved in thyroid hormone synthesis except iodide trapping. Otherwise, everything is controlled by thyroid peroxidase. Iodide trapping is done by NIS. What is NIS? This is the sodium iodide symporter. This is not under the control of the thyroid peroxidase enzyme. Thyroid peroxidase enzyme will control the oxidation of I- to I2, organification of iodine, that means iodine and combining with tyrosine. Coupling reactions are controlled by thyroid peroxidase, but not iodide trapping. Which of the following enzymes is responsible for conversion of T4 to T3 in peripheral tissues? This is called iodothyronin deiodinase 1. This is also known as 5-deiodinase. Iodinase type 2 is known as 5-deiodinase, and this converts the T4 to reverse T3. Sorry, once again, iodothyronin deiodinase is 5-deiodinase. This converts T4 to T3. And the type 2 is 5-deiodinase, which converts T4 to RT3. Right? So once again, iodothyronin deiodinase is 5-deiodinase, which converts T4 to T3, and this type 2 will convert T4 to reverse T3. A female complains of cramps in the breast while breastfeeding. Which of the following hormones is responsible? Oxytocin, because it is causing contraction of the myoepithelial cells around the ducts. Which of the following hormones regulate serum calcium levels? All, isn't it? Calcitonin. Parathormone increases plasma calcium levels, decreases plasma phosphate. Vitamin D will increase plasma calcium as well as increase plasma phosphate. Calcitonin will decrease plasma calcium and increase plasma phosphate. So all of the above. Insulin acts on glucose metabolism by insulin will increase GLUT4. Where is GLUT4? GLUT4 is present on adipocytes and on muscle cells. So that means it increases the glucose uptake by facilitated diffusion. GLUT, we've already discussed right at the beginning, is an example of facilitated diffusion. Cervical dilatation delivery on uterine contraction is similar to which of the following? It is done by oxytocin. So similar to milk ejection by oxytocin. So these are some important PYQs which have been asked. Which of the following is not an effect of parathormone? Parathormone will increase the bone resorption. Yes. It increases the calcium reabsorption in the kidney. This is also true. It decreases phosphate reabsorption in the kidney. So this is not an option. Increases calcitriol synthesis. So it does not cause C. Please remember one important point. Where are the parathormone receptors present? Parathormone receptors are present on osteoblasts. Calcitonin receptors are present on osteoclasts. Remember, C in osteoclasts, calcitonin receptor. Which of the following effects of puberty are not mediated by estrogen? This is the last question, and that is hair growth. All the others are mediated by estrogen, right? So this is as far as we've had a fantastic discussion of all the high yield topics of physiology. I hope you found the session useful. I hope that you have been able to understand all the concepts which I've tried to take up, all the important high yield topics which I've tried to take up in today's session. What I must end this session with is all my best wishes to each one of you to perform well in the exam which is coming up. Like I told you right at the beginning, keep calm, keep cool, and be confident. And I'm sure you will ace this exam. It is all very, very doable, but keep calm, keep cool, be confident. Thank you very much, and I'm giving you my email ID, which is Dr. Anupama Devgan @gmail. Please feel free to ask me any doubts if you might have. My Facebook page and Instagram page is Dr. Anupama's Physiology. Feel free to send me a direct message, and I will try and answer all your queries. Thank you very much, and God bless.